Bismillahirrahmanirrahim. This is the screencast for thyroid gland pathology. Okay, so as usual, we expect certain things you guys to do after this lecture. So that is called our intended learning outcome. So I hope inshallah you guys can able to list the causes of hyper and hypothyroidism after this lecture, and you guys can also explain the pathogenesis of hyper and hypothyroidism and its effect on various systems. Explain the pathogenesis of especially the Graves' disease and Hashimoto thyroiditis, as well as describe the morphology of thyroid in various goiters, thyroiditis, thyroid adenoma and thyroid carcinoma. Actually, this part we are also going to cover in the practical part more. We already had a session. So this is very important one, and you can able to compare and analyze the clinical feature, hormone profile studies, iodine isotope scanning, ultrasound images, cytological and histopathological findings, and arrive at diagnosis. See, lot of information you have to compare and analyze when you want to come to a diagnosis in thyroid diseases. My dear students, thyroid disease looks very easy to diagnose only in the book. On reality, it creates a lot of gray zone areas to come to a final conclusion. Understand? So keep that in your mind. I'm not making you guys to like kind of phobia towards the thyroid diseases, but keep that in your mind that it is an integrated diagnosis, which means you need the help of all the people, especially the pathologist and the radiologist, and put all these findings into your clinical features, and then only you can come to a conclusion in thyroid cases. As usual, you guys know our style of lecturing, like we'll start with basics, and we already discussed in the pituitary. Hypothalamus is the one controls the pituitary gland, and pituitary gland releases thyroid stimulating hormone, and that goes and stimulate the thyroid gland, and they release T3, T4. Okay, so now let's see the thyroid gland. It has two lobes and connected by the isthmus. And if you guys see the thyroid fall in histology, there are a lot of small follicles of varying size. Okay, you can see something is filled in, that is called thyroglobulin or colloid, and these follicles, just I draw a follicle here. It is all lined by small tiny cells which we call thyroid follicular cells. They are cuboidal or low columnar cells, depends upon their activity, and these cells produce this thyroglobulin colloid. It is full of like this, the complete thyroid gland. So thyroxine is T4 and triiodothyronine is T3. Once they are released, they get bind with plasma protein and thyrotin, and free T3 and T4 will be less. T4 is getting converted into T3 in the periphery, and T3 has more affinity towards thyroid hormones. So free T3 is dangerous, because more increased, not dangerous, if there is increased free T3, yani like it stimulate, it produce hyperthyroid effect. And in between the follicles and surrounding the follicles, we have C cells that secrete calcitonin, that plays a major role in calcium balance. Now coming to the function of thyroid hormone. See, thyroid hormone accelerates the carbohydrate and lipid catabolism and stimulates the protein synthesis, and that net result is increase in the BMR, basal metabolic rate. And in neonates and infants, okay, they really play a major role in brain development. That's why if the hypothyroidism comes in the infant and neonates, it affects their brain development. They become mentally retarded. So this is the thing you should keep in your mind. So we classify the disease, most of the endocrine diseases, this is the way we classify. If they increase their hormone, it is called hyperthyroidism. If they if they decrease their hormone, it is called hypothyroidism. Or it can produce mass lesions of the thyroid. Remember, in the kingdom, yani this is a real issue. Now coming to the hyperthyroidism, otherwise called as thyrotoxicosis. Remember, thyrotoxicosis is the word we use mostly for the Graves' disease. So we are going to make this concept into two large categories. Okay, to two large categories. One is in this category, so just we number it like Roman number 1 and Roman number 2. So in this category number 1, here the thyroid gland is hyper functioning. Here the thyroid gland is normo functioning. You understand? But in both states there is increased thyroid hormone. There is increased thyroid hormone. I hope you guys got my point. It's very important to categorize into these two. Please try to understand. Most of the books in pathology, they don't discuss in like this. So two categories. One, increase the function of the thyroid gland, that leads to increase in thyroid hormone. Here in the group 2, the thyroid gland is normal but thyroid hormone are increased. Then we should know how these thyroid hormones are coming. So that really tells us the cause of this increased thyroid hormone. So let's discuss one by one. The category 1. So the primary disease, that is something is stimulating the thyroid gland directly, that is could be of Graves' disease and hyperfunctioning goiter, or it could be of hyperfunctioning adenoma. Secondary is like there is a pituitary tumor which secretes more TSH, that is stimulating the thyroid gland, and it is not primarily a problem in thyroid, actually it is a problem of pituitary, and so the end is the thyroid becoming hyperfunctioning. So it is called secondary hyperthyroidism caused by the TSH secreting pituitary adenoma, but it's a very rare event. Now coming to the most important and confusing category, that is called normal functioning thyroid but increased thyroid hormone. This is the one. So remember, if there is a thyroid gland, okay, and there are some kind of inflammation, these are the inflammatory cells and they are coming and destroying the follicle. What happens when they destroy the follicle? The thyroid hormone, okay, let me draw a little bit big so the students who are like visual learners, they will get benefit. So let me try to draw thyroid big. 5. So you all know this thyroid has lot of follicles, guys, and lot of follicles in the isthmus, in the lobes. Okay, now this, guys, this lymphocytes, okay, sometimes these lymphocytes become a monophic, okay, which means they destroy their own body because they are produced from that body and they destroy that body itself. So they go and attack these follicles, right? And you all should know this thyroid, this thyroid follicles are surrounded by blood vessels. They are surrounded by full of blood vessels. All endocrine glands are highly vascular glands, vascular organs. Understand? They are surrounded by these blood vessels. So if these lymphocytes are attacking the thyroid follicle, what happens? The hormones which present inside the follicle, they get escaped into the blood vessels. So suddenly there will be increase in the thyroid hormone. So lymphocyte attacking the thyroid gland, it is called thyroiditis, inflammation of the thyroid, and that initial stage they destroy the follicle and they increase the thyroid hormone. So that's why in granulomatous or any thyroiditis you see there is increase in thyroid hormone in the early stage. In the late stage, what happens? They completely destroy, and full of lymphocytes, and if you see, it is like completely destroyed and there is no follicles itself to produce thyroid hormone. They go for hypothyroid state in the late stage. What is happening here? Late stage thyroid hormones are decreased. So now you guys know why in thyroiditis there is increased thyroid hormone in the early stage. Okay, now let us discuss another condition. It is very easy. See, there is a normal functioning thyroid. There is normal functioning thyroid. Okay, let's draw the thyroid little bit in smaller size. Here the thyroid is normal functioning, and we have a female. Okay, they have fallopian tube, uterus, cervix, and they have ovary. So this ovary is little bit large. It is having a tumor, and this tumor is full of thyroid follicles, like what you see in the normal thyroid gland. So this tumor is called stroma of ovary. It is a type of monophasic teratoma. What happened? They secrete T3, T4, increase the thyroid hormone, and that causes hyperthyroidism. Okay, it's a kind of ectopic hormone. Now, sometimes, actually not sometimes, we give thyroid drug, hormone as a drug for hypothyroid patients. So if they take too much of dose, that will lead to hyperthyroidism. Okay, these are the conditions which keep the thyroid functioning is the main thyroid gland, the functioning is normal, but other reasons which is causing the increase in the thyroid hormone. I hope you all understand these two categories. Okay, whenever I am talking about these categories, I am talking about hyper functioning thyroid, normal functioning thyroid. So we use the word called euthyroid status. Euthyroid status for telling that it is normal functioning thyroid. So what guys has to understand is how we see they are normal functioning and they are hyper functioning, because in this condition both thyroid hormone is increased, right? Thyroid hormone is increased, but here it is thyroid gland is functioning more. Here the thyroid gland is functioning normal. So what we do is we give you a radioisotope, we do radioisotope scan. Here we give radioisotope iodine, so that goes to the patient, and if the patient having hyper functioning thyroid gland, so all will be get absorbed, more iodine enters, more iodine enters, more iodine enters. Okay, there will be diffuse intake of iodine if whole thyroid gland is hyper functioning as in the state of Graves' disease, or if it is in the state of adenoma. Okay, there is a tumor here, only that tumor is hyper functioning, then more iodine goes there. If it is normal functioning, the normal amount of iodine goes there. So when normal amount of iodine goes there, it is called warm, and more amount of iodine goes, it is called hot, and this is also called hot nodule. It is called diffuse hot thyroid, this is called hot nodule, and this is called warm thyroid. And another thing you also can have, there are certain conditions in hypothyroid. For example, the whole thyroid gland is destroyed by the lymphocytes. Do you think the thyroid can take radioactive iodine? No, right? So then automatically it is called cold thyroid, where they cannot take iodine, radioisotope iodine. So this is can be seen in the radioisotope scan. Understand? So these are the things you should keep in your mind when the people talk about normal functioning of thyroid gland and normal functioning or hyper functioning of thyroid gland, which means they know really the thyroid gland functioning status. Here we don't see the hormone and we don't say that it is hyper functioning thyroid gland. Okay, when we see only the hormone, we will tell that it is hyper hormone status. Understand? Okay, what are the clinical features of hyperthyroidism? So it increases the metabolic state, and they also make the sympathetic system becomes overactive. So otherwise we call increase in the beta adrenergic tone, and remember the patient will become like soft, warm, flushed, and there is increased blood flow and peripheral vasodilation just to send the heat out. Understand? So there is heat intolerance, and there is increased sweating, and there is, I said, increased basal metabolic rate. Because of that the patient loses weight, increase in the appetite. So now cardiac manifestation, they increase the cardiac output because they increase the sympathetic activity and they increase the cardiac contractility, and they will end up with tachycardia and palpitation, and as well as end up with cardiomegaly. The most important thing is they produce arrhythmias, and it is very dangerous in the old patient. And neuromuscular activities become overactive because of the sympathetic nervous system, hyperactive sympathetic nervous system. They produce tremor in the, they disturb sleep or characteristic feature, and they are emotionally labile, and they have lot of anxious disorders. And it affects the muscle, it is also affect the proximal muscles, it is called thyroid myopathy. And characteristic ocular changes, believe me, it will be very characteristic, and wide staring gaze like this, and there will be lid lag, okay, and sympathetic over stimulation because of they affect the levator palpebral superioris. So the thyroid true ophthalmopathy is called exophthalmos proptosis, that is seen in the Graves' disease. So gastrointestinal system become hypermotile, and that's because of that malabsorption takes place and they end up with diarrhea. And skeletal system, remember, they also produce osteoporosis, increased thyroid hormone, make the bone to resorb more calcium, and that results in osteoporosis. And thyroid storm, which we call it as a sudden increase in hyperthyroidism, it is really a medical emergency. Sometimes happens during the surgery removal of thyroid. The thyroid hormones escapes out into the circulation, and remember that results in serious cardiac arrhythmias, and we have to treat them very fast to make the rhythm normal. So apathetic hyperthyroidism means the thyrotoxicosis is occurring in the elderly people. Now coming to the diagnosis of hyperthyroidism, see, the clinical findings are characteristic. Okay, the patient have intolerance to heat, and they have lot of sweating, they have lot of, if it is a female, they have menstrual abnormalities, and they have like tremors, and they have characteristic ocular changes, and sometimes if it is severe, you see the eyeball protruding out, and they have mental instability, and they are very anxious, and they will have serious tremors or sometimes fine tremors. So you should know all the clinical features, and then we suspect hyperthyroid in that patient. And even if there is an infertility, we will check the thyroid status, and hormone levels will show if there is true hyperthyroidism. There is low TSH because of negative feedback, and there is increase in the T4 and T3, and that is called, there is more T3, it is called T3 toxicosis. And remember the radioactive iodine which I explained, and if it is a Graves' disease, the iodine uptake will be increased in the whole gland. If it is solitary nodule is taking, then we talk about it is called toxic adenoma. In the lab sessions, I discussed that toxicity in hyperthyroid, in thyroid diseases, we mean hyperfunctioning. So decreased uptake can be seen in the decreased uptake of iodine can be seen in the thyroiditis. So let's go to the hypothyroidism. We again classify them into two groups, but it is very simple. It's not so confusing like hyperthyroidism. So primarily some problem in the thyroid gland. It is called primary hypothyroidism, and you guys can say that it's a developmental defect. I gave an example, real-time example actually. One of our colleague who used to work here, and mashallah, is a very good Muslim family, and his son has congenital absence of thyroid. Mashallah, but he's so active kid, and that's what actually health is really connected with Allah subhanahu wa ta'ala. So may Allah give all of us a good health to fulfill the obligations of all of our duties. So now congenital defect in hormone synthesis leads to hypothyroidism. Iodine deficiency, even though I say it is very common, it's an old days ideology that is. Now we have all iodized salt, now it is not seen much, and drug or surgery or radiation can cause hypothyroid, but nowadays this is the big problem, autoimmune disease of thyroid gland that produces hypothyroidism because they destroy the thyroid, thyroid gland. So if there is a pituitary or hypothalamic failure, okay, so that also results in hypothyroidism because there is no TSH cannot be produced automatically. TSH is less, there is reduced T3 T4. So this will be the hormonal status in secondary hypothyroidism. Whereas in primary hypothyroidism, if the pituitary is normal, the thyroid cannot secrete T3 T4, but this ends up with positive feedback on pituitary. They increase the TSH. So this is what the hormonal profile in the primary hypothyroidism. So clinical feature, the produce cretinism, and it is childhood hypothyroidism. Remember, they affect the central nervous system, and mental retardation will be very characteristic, and they have like other features like protruding tongue and coarse facial feature or umbilical hernia, all the other stuff, but the characteristically they will be having serious mental retardation. So mental retardation will be more if the mother is having hypothyroid, maternal thyroid deficiency before the development of fetal thyroid gland. So in that case, mental retardation will be very severe. Now coming to the mixed edema, which is adult hypothyroidism, and what you see is the mental sluggishness. They'll do very slow activities, and they become cold, exact opposite of hyperthyroidism. They become cold intolerant, they have overweight, and they have constipation and decreased sweating, and they have reduced cardiac output. The biggest problem here in their cardiac, they produce more cardiac disease because they become more atherogenic, which means they produce more atherosclerosis because of increased total cholesterol and low density lipoprotein. So increased LDL and increased total cholesterol will be characteristic feature of hypothyroid status, and that is seriously they have anytime cardiac diseases, serious cardiac disease like myocardial infarction. Histologically, they have increased accumulation of the connective tissue ground substances like glycosaminoglycans and hyaluronic acid in the skin and subcutaneous tissue as well as in the organs, and that will produce non-pitting edema, and that leads to the very coarse looking face and enlargement of the tongue and very deep voice. So this is the patient of hypothyroidism. See how she becomes pleasant when after treatment. So this is the characteristic feature of hypothyroidism. You can see a broad lips and broader nose, and you can see connective tissue deposition here, and the face becomes like more deposition of the connective tissue here, and it is become very coarse. So just after the treatment it becomes normal. So now coming to the diagnosis of hypothyroidism, the characteristic clinical feature will be of unexplained increased weight gain and hypercholesterolemia, increase in the lipid profile. And when you see the hormone profile, TSH level will be increased in primary hypothyroidism as a result of loss of feedback inhibition of TRH and TSH production of hypothalamus and pituitary gland. Okay, if it is a pituitary disease, the TSH level is not increased. Understand? Keep that in your mind. So TFO levels are decreased in individuals with hypothyroidism of any origin. Okay, this is another gray zone. So now coming to the thyroiditis. Thyroiditis means inflammation of the thyroid gland. The cause varies whether from infection to the autoimmune disease. So infection can cause acute bacterial thyroiditis, or even tuberculosis can infect the thyroid gland, and sometimes we do this like too much of infection will leads to palpation thyroiditis, too much of examination, that is palpation examination, that leads to the thyroiditis. And autoimmune thyroiditis, Hashimoto thyroiditis is very important. The pathogenesis is the lymphocytes go and destroy the thyroid gland. Lymphocytes goes and destroy the thyroid follicles. Initial stage they have increased TSH because the follicles, hormone from the follicles escape out, then they destroy all the follicle, they replace with completely lymphocyte. This thyroid gland will be replaced completely by lymphocyte. It leads to hypothyroidism. And remember, they produce a special cell change called Hurthle cell change. Hurthle cell change, which we also discussed in the lab. So keep this in your mind. And these are the pathogenesis of Hashimoto thyroiditis. The most dangerous part is they produce this kind of cancers, that is lymphoma, papillary carcinoma, Hurthle cell carcinoma. So if the viral induced thyroiditis will be very painful, and that is called granulomatous thyroiditis, and sometimes after the delivery we get the thyroiditis that is called subacute lymphocytic thyroiditis. There will be painless swelling. And readers thyroiditis, they become very stony hard, and it is like obstructive, like which means constricting the neck, that is called fibrosis. So this is called readers thyroiditis. So these are the different thyroiditis. The most important one is Hashimoto thyroiditis. Now coming to the hyperthyroid disease, special disease called Graves disease. Okay, because it produces characteristic three clinical finding: diffuse swelling of the thyroid gland, and exophthalmos, which is otherwise called infiltrative ophthalmopathy, and they produce peritibial myxedema. Okay, they produce infiltrative dermopathy. And as usual, like other autoimmune disease, it is very common in the 20 to 40 years of age, and especially in the female. And remember, this thyroid gland has thyroid follicles, and just I am taking out one follicle, and this follicular cells have receptor for thyroid stimulating hormone. So it is called thyroid stimulating hormone receptor. So what is this is called? These receptors are called thyroid stimulating hormone receptor. So this person will have antibodies, okay, that will come and act on this. Okay, otherwise we make a receptor in different shape. So these are the thyroid stimulating hormone receptor, and the thyroid stimulating receptor will be attacked by these antibodies. These antibodies are called thyroid stimulating immunoglobulins. So once they sit on the thyroid stimulating hormone receptor like this is the thyroid stimulating hormone receptor, this is the antibody. Once they sit on this like this, they immediately stimulate the thyroid follicular cells to secrete more hormones. That's why they result in increased thyroid hormones. Understand? So because of increased thyroid hormone that produce negative feedback, that will decrease the TSH. So this is will be the hormonal profile, and let's see what are the things they do. So what they do is they produce characteristic Graves ophthalmopathy. What they do is, this is the for example, this is a lateral view, this is the person's eye, and this is the area which is called retroorbital area, that is, this is eye orbit, the area beneath the eye, it is called retroorbital area. What happens is the inflammation happens here. Okay, mononuclear cells goes and they produce serious edema, and they increase this connective tissue substances, and they push the eyeball out. After a period, that will be completely replaced by the fat cells. So this is the problem in the Graves ophthalmopathy. So these are the three characteristic clinical features, that is diffuse hyperplasia of thyroid gland, and wide staring gaze, exophthalmos and lid lag, and peritibial myxedema. I will show you the picture of peritibial myxedema, you will understand. So there will be elevated T4, T3 levels and decreased TSH level. The radioisotope iodine scan will show diffuse uptake of thyroid of iodine, and these are the drugs they give, like beta blockers and antithyroid lag like thionamides, and radio iodine ablation or surgical interventions. So this is the exophthalmos, and the patient after the treatment they become normal, and this is the cushion like covering over the tibial shaft, that is called peritibial myxedema. So now coming to the diffuse and multinodular goiter, and goiter means generally it is called enlargement of the thyroid gland. For example, if the person is have different follicles in the thyroid gland, it is not iron actually, it is iodine. So what you have to understand from here is, if there is any problem in the thyroid hormone synthesis, the thyroid hormone is not synthesized, T3, T4 is reduced. So what happens? This goes to the pituitary gland, and pituitary gland releases more TSH. Then TSH stimulate the thyroid gland. Okay, so if you see the TSH, what they do, the thyroid cells has TSH receptor. The TSH goes and sits here, right? The TSH goes and sits here and stimulate. So what you have to understand is the thyroid follicular cells will not have equal amount of receptors. If they have all are having equal amount of receptors, then they will result in diffuse hyperplasia of thyroid. If they have variation in the number of receptors, so those which has more receptor, that will go for bigger hyperplasia. Those who have less receptor, that will go for very less hyperplasia. So that results in multinodular goiter. So this is what I am explaining here. So that could be diffuse goiter or multinodular goiter. Disharmogenic goiter is very huge swelling because there is some kind of defect in the enzymes, hereditary defect in the congenital defect in the enzymes, and that leads to the decreased T3, T4, that will be releasing more TSH. They stimulate more the thyroid gland, and they go for increased size of the thyroid gland. So what are the things can interpret iodine uptake of in the thyroid cells? These are the vegetables, okay, cassava, cabbage, turnip, Brussels sprouts, and they have, for example, cassava has thiocyanate, which inhibit the iodine transport. Then T3, T4 is not released, so that is decreased T3, T4. Then that will lead to increased TSH. Increased TSH will go and stimulate the thyroid gland, and the thyroid gland will become like very big thyroid gland. Understand? Goiter is formed. So now coming to the thyroid neoplasms, remember any organ we divide the neoplasms into benign and malignant. Even the benign tumors are very common, but in the kingdom, thyroid gland stands as the second commonest tumor in the female. So please keep in your mind. Actually, this data may be old, but 2007, but I don't find any recent data in the Saudi Cancer Registry. So now thyroid neoplasms, like most common benign tumors or follicular adenoma. There are 4 common types of thyroid carcinoma. Like papillary carcinoma, which is the most commonest one, which is seen in the 25 to 50 years of age group. And remember, this tumor always diagnosed most of the times after they go to the cervical lymph node, which means after metastasis we usually find this tumor, because the tumor will be very small in the thyroid gland. It will be very small, like less than 1 centimeter of size, so it will not be expressed as a swelling. And what they do is they spread to the lymphatics, and they go to the this is a collarbone, and they go to the cervical node. It goes to the cervical node, and it will be, the patient will be coming as a neck node swelling, or cervical supraclavicular node swelling, or anywhere they come as a nodal swelling. And if you do the FNAC and if you do the biopsy, you will be seeing the tumor which is having full of papillary structures, and it is a papillary carcinoma of thyroid, but it has very good prognosis. Okay, so now coming to the follicular carcinoma of thyroid, like it is it comes in above 40 years of age, but it spreads to the blood, and it is a bad prognostic tumor. The most dangerous of all is anaplastic carcinoma. It is produce serious mass effect. They constrict the throat, they produce difficulty in swallowing, difficulty in breathing, and they involve the recurrent laryngeal nerve, and they produce hoarseness of voice, and they are very aggressive and dangerous tumor. Whenever the word we use anaplasia, it is like aggressive and dangerous, and it is a very, very bad prognosis. The patient die within 1 year of time. Medullary carcinoma, and it comes from the C cells. They produce lot of ectopic hormones like vasoactive intestinal polypeptide adrenocorticotrophin hormone, and they produce the effect of those hormones. Okay, usually they are associated with multiple endocrine neoplasia type 2 syndrome. This ends the screencast for thyroid gland pathology. So you can use other learning resources from the Robbins Basics Pathology textbook, especially the Suggest 9th edition. And if you guys feel the Robbins is extensive, otherwise you can use our brother Dr. Hussain Sattar's book, Pathoma. I recommend you guys to not to use the pirated one. Okay, please give respect to the people who is working on the field. It will encourage them to do more academic works. So better to get registered under those websites and get the book. And if you guys can't read Robbins, my strong suggestion is study Robbins and try to get a teacher to study Robbins under him. It helps you a lot in clinics. So especially you guys are preparing for step 1. Okay, this is the stage you can study the Robbins. Okay, so now let us conclude this screencast. I hope this benefits you.